Vale, nuestra siguiente ponente es la doctora Paivi Karjalainen, que es de Finlandia. Con Paivi coincidimos en Australia. 6 months we were together. Yeah. Y ella nos hablará de una pregunta que yo supongo que todos los que tratamos prolapso siempre tenemos, ¿no? Cuando tenemos una paciente con prolapso y síntomas de vejiga hiperactiva o de urgencia, ¿tenemos que corregir el prolapso primero o podemos tratar la urgencia ignorando o no teniendo tanto en cuenta el prolapso? ¿Y qué grado de prolapso tenemos que tratar? Thank you.
Good morning everybody. Thank you, Joan, for the invitation. Girona is beautiful. So yeah, Joan has given me the topic to speak on this question. Does prolapse surgery improve OAB symptoms? And during my training, I noted that there is a lot of differences in how different specialists would approach concurrent prolapse and OAB symptoms. One would do surgery very aggressively, even for minor prolapses, and then another would ignore the prolapse if the woman wouldn't be very much bothered by it, and treat OAB only, OAB symptoms through medication. And the same can be seen also in the literature, I think. And usually, if there is so much discrepancy in the ways we approach a problem, usually it means that there is lack of evidence behind that problem. But during this next 30 minutes, I will try to answer the question Joan gave me by looking at the evidence we have. So is there evidence to suggest that prolapse and OAB have a causal relationship? By answering, is OAB more common in women with prolapse? And do OAB symptoms improve after treatment for prolapse? And if there is a relationship, is it related more to a certain compartment of prolapse, or is it any kind of prolapse? And if the symptoms improve, can we predict who is going to improve? So Adi already provided us a lot of information on OAB, but yes, it is a symptom syndrome, which is characterized by urinary urgency, with or without urgency incontinence, and usually with frequency and nocturia. And the diagnosis is based on symptoms, and we don't need urodynamic studies. In fact, only 50% of women with OAB symptoms would show detrusor overactivity. And we have to exclude UTIs and other obvious pathology. However, the other obvious pathology is not specified. The pathophysiology of OAB is poorly understood. It's complex, that we know. But to put it in a very simple way, the urgency can originate from decreased capacity of the brain to handle the afferent signals from the bladder, or increased afferent signals from the bladder or the urethra. And until now, we have usually thought that if OAB symptoms are not of neurogenic origin, then we often think that it's idiopathic, and we treat it in a linear way, treat everybody similarly, and taking step after step and trying to find the solution. However, recent evidence implies that most probably OAB is it has many subtypes and many different mechanisms behind it. And probably in the future we should try to identify these subtypes and tailor our treatment accordingly. So we should differentiate OAB, neurogenic OAB and non-neurogenic OAB, but also try to identify the cause behind the non-neurogenic OAB before naming it idiopathic. So can prolapse be obvious pathology behind the OAB symptoms? Can it cause OAB symptoms? To answer that, we could have a look if OAB is more common in women with prolapse. And this is a review article from 2010, which has collected all the evidence until that year. And indeed, it seems that OAB symptoms are more prevalent in women with prolapse in comparison to in comparison to women without prolapse. The prevalence seems to be 2 to 6 times higher in women with prolapse than women without. And what about how do the symptoms improve after prolapse surgery? So this same review article had data from 19 studies where women underwent prolapse surgery, and all except one showed improvement in OAB symptoms, and the post-operative symptoms also included the de novo symptoms. So actually all of them reported improvement of pre-existing OAB. And also from the same review article, also pessary treatment seems to improve OAB symptoms. So for the question Joan gave me, does prolapse surgery improve OAB symptoms? I cannot answer because we don't have any RCTs that would compare the prolapse surgery with conservative measures or sham surgery. So we cannot be sure whether that improvement is from the surgery itself or if it's only showing the natural cause of OAB. Adi just told us that there's also quite a lot of regression of symptoms, or if there is a placebo effect. But it's safe to say that OAB symptoms tend to improve after prolapse surgery. So one of my colleagues would say that no, the woman is not bothered by the prolapse, so I will treat the OAB symptoms with medications only. Do we have evidence for that approach? Not really. I only could find one study looking at that question, and it included 235 women with OAB symptoms and detrusor overactivity. And when they compared women having anterior prolapse to women without prolapse and treated them with tolterodine for 12 weeks, both groups improved, but the women without prolapse improved more. All right, so now we think that prolapse is associated with OAB symptoms, and the symptoms also seem to improve after surgery. But how is it? Is it any kind of prolapse, or is it only certain prolapse compartments that are associated with those symptoms? The theories about the mechanisms that induce the OAB symptoms in women with prolapse, the most common or popular one is from bladder outflow obstruction. that would cause denervation or changes in the detrusor muscle. A second theory would suggest that maybe the anterior wall distension would stimulate the stretch receptors in the urothelium. So both of these theories are sort of suggesting that maybe OAB symptoms would be more common in women with anterior compartment prolapse. However, the evidence doesn't seem to show it. So there's very weak or even non-existing correlation between the OAB symptoms and the prolapse compartment or degree of prolapse. And also the symptoms seem to improve similarly regardless of the compartment of prolapse surgery. So I've been doing research on this FinPop cohort, and I thought that I have so many women in this cohort that maybe just those other previous studies, they didn't have enough women, lack of power, or they had poor methodology. And it must be so that it's related to the anterior wall prolapse. So we aim to estimate whether OAB symptoms are more strongly related to anterior and apical compartment prolapse than with the posterior compartment prolapse. So FinPop cohort is the cohort from prolapse surgeries from 2015. We recruited women in whole Finland to participate, and we include 82% of the prolapse surgeries that year in Finland. And for this study, we included the women who had baseline questionnaires and also one of the 6 or 24-month questionnaires available. And we excluded women with 25 women with concomitant sling surgeries or women who had secondary slings during the follow-up, 84 of them. And then we compared women who underwent anterior or apical compartment prolapse to women who did not have surgery for anterior or apical compartments. And our primary outcome measure was 2 questions in the PFDI 20 questionnaire. So one question about urinary frequency and one question about urgent urinary incontinence. So when the woman answers, yes, I have that symptom, then she grades the bother she has from that symptom. So 1 would mean that, no, I'm not at all bothered by the symptom, and 4 would mean, oh, yes, quite a bit bothersome for me. And then answers 3 and 4 we defined as bothersome symptoms. The limitation is that we did not have a question about urgency because PFDA 20 does not include it, and we don't have frequency volume charts for these women. So when we looked at the association between prolapse and OAB symptoms at the baseline before the surgery, we found an association in urinary frequency between urinary frequency and anterior and apical prolapse. And for urgent urinary incontinence, we found association between urinary urgency incontinence and anterior wall prolapse, and a negative correlation with the posterior compartment prolapse. But even with these big numbers we had, the correlation is very weak. So in general, 80% of the women at baseline reported either of the 2 symptoms of any degree of bother, and 40% would report bothersome frequency or urinary urgency incontinence. But here the frequency had the strongest association with anterior wall prolapse. And for women who had stage 0 anterior wall prolapse compared to the bigger stages of anterior wall prolapse, there was only increase of 10% in the frequency. So very, very small, not very weak correlation. So in general, all of the women had quite often these symptoms. What about the change of in the symptoms after surgery? So the women who had anterior or apical compartment surgery, they started with more symptoms, more OAB symptoms. They improved more after the surgery, and after the surgery, these two groups they had similar level of symptoms. And if we divide the anterior and apical compartment surgery and see them separately, anterior and apical prolapse surgery induced similar changes. And then there are many ways how to look at the to describe how the symptoms changed. But if we see how if we see women who had bothersome symptoms at baseline, for frequency, for the anterior or apical compartment prolapse, they would have persistent bothersome symptoms in 18%. Posterior compartment prolapse surgery would have more often persistent symptoms in 37% of cases. And urgency urinary incontinence would improve less often compared to frequency symptoms. And bothersome de novo symptoms were rare, only 1 to 3%. Okay, so symptom improvement is incomplete. We can't cure everybody with prolapse surgery. So can we predict who is going to have persistent symptoms? And previous literature is not very helpful in regards of this question either. The results are very inconclusive and even inconsistent in regards of those predictors that they have looked at. So not helpful. So this is a horrific table. This is still unpublished data from the FinPop study. But if you have a look on the left, we put in the same prognostic model all those potential prognostic factors. So bother of the OAB symptoms, age, BMI, the degree of prolapse, prior surgeries, whether the patient reported bothersome bulging or it was not bothersome stress incontinence or bothersome voiding dysfunction, and type of the surgery. And here I've taken only the factors that remained significant in the multivariable model. So for frequency, prognostic factors for persistence after surgery would be that the women who had more severe symptoms in the beginning were more likely to have persistence of symptoms. Older women were more prone, and women undergoing posterior compartment prolapse. Whereas the women who had advanced anterior or apical compartment prolapse, they would improve more often. How much time, Joanne? Yeah. So here I've tried to illustrate how the baseline bother impacts the changes in the OAB symptoms. So this is for urinary frequency, women undergoing anterior or apical compartment surgery. So if you rated 4 in the beginning, so you had quite a lot of bother from the symptom, they would improve in 40. They would resolve. The symptom would resolve in 44% of the times. Whereas if you rated 2, so somewhat bothersome, yes, they would improve more often or resolve more often. And then one would think that, okay, so I have a small anterior wall prolapse, or should I operate it or not? So here for bothersome frequency and bothersome urgency incontinence, the persistent of bothersome symptom is shown. So women who had stage 0 anterior wall prolapse, so they would have posterior wall prolapse instead, had persistent frequency in 1/3, and if they had a large anterior wall prolapse, they would have persistence of symptoms in 1/5 of the times. And for urgency incontinence, the numbers are again a little worse. So we didn't find what I expected, and I was not expecting that a posterior compartment surgery would also lead to improvement of those symptoms so often. And so why would that be so? It's probably so that even the posterior compartment prolapse quite often could induce voiding dysfunction and bladder outlet obstruction. Maybe that's one of the reasons. And why do these symptoms persist so often? So why cannot we improve all of them then with the surgery? Some studies have implied that if you have a long-lasting bladder outlet obstruction, maybe you get irreversible changes in the detrusor muscle. But most probably the reason is that OAB is just so multifactorial in nature that it's natural that prolapse surgery is not addressing, let's say, diabetic metabolic syndrome or stuff, so they still have these risk factors, and those we cannot address with the prolapse surgery. So to summarize, OAB symptoms are very common in women with prolapse, and they are more common in women with anterior or apical compartment prolapse in comparison to posterior. But posterior compartment prolapse also, these women have quite often these symptoms. And bothersome urinary frequency and urgency incontinence improves or resolves in 60 to 80% of cases, and they do so more often after anterior or apical compartment surgery, more often in cases of mild baseline symptoms, and the persistence of those symptoms is likely related to the multifactorial nature of OAB. But it seems that in many cases it's reasonable to treat the prolapse to address OAB symptoms. However, it's crucial to provide the patient with the information that we are not able to improve everyone. Thank you very much.